You took the vitamin D. Your doctor checked the level. It came back normal. But here's what nobody connected for you. That blood test measures raw material. And if your kidneys are at stage 3, the factory that turns that raw material into the form your bones and arteries actually need is running at half capacity, and nothing on your lab printout can see it. A team led by Dr. Rachel LeClaire at Indiana University published a cross-sectional study in the American Journal of Kidney Diseases in 2005, spanning multiple latitudes across the United States. They found that between 71 and 82% of adults with CKD stages 2 through 4 had insufficient vitamin D, even among people who were supplementing. That number should have changed how kidney doctors talk to you about vitamin D. For most of them, it hasn't. If you're new here, this is where we cover the tests, the numbers, and the conversations that protect kidney function long-term. One number per video, evidence only. Subscribe and turn on notifications so you don't miss it. So here's the answer. Up front, no waiting. Your kidneys contain an enzyme called 1-alpha hydroxylase. It takes the storage form of vitamin D, the one your blood test measures, and converts it into the active usable form called calcitriol. When kidney function drops, that enzyme's output drops with it. The standard blood test measures the storage form, called 25-hydroxyvitamin D. It can sit at 35 nanograms per deciliter, normal range, and still hide the fact that your kidneys aren't converting enough of it into the form that actually works. In the LeClaire study, fewer than 30% of people at CKD Stage 3 and fewer than 20% at Stage 4 had vitamin D levels considered adequate. That's the headline. But knowing the enzyme's name won't protect you, because whether this is happening inside your body right now depends on something your last visit almost certainly didn't check. Here's where it splits into two very different situations. The first sounds like this. Your vitamin D came back at 35 nanograms. Your doctor said it was in range and you moved on. For some people, that reading is accurate. Their kidneys are converting the storage form into calcitriol just fine, and everything downstream, bones, parathyroid gland, artery walls, is getting what it needs. But here's the other side. For someone whose eGFR has slipped below 45 or even below 60 with other risk factors, that same 35 on the blood test is measuring a warehouse full of raw material that isn't being processed. The conversion enzyme has slowed down, calcitriol is dropping, and the body has already started compensating in a way that quietly thins your skeleton and stiffens your arteries. You are sitting in one of those two situations right now, and the only way to know which one is yours is to understand what happens when that enzyme slows and to ask for the one number that reveals it. Pause. By the end of this hour, you'll know which of those two situations is yours. You'll know the one test that tells you whether your vitamin D is reaching its active form, a test most primary care visits never order. And you'll have the exact sentence that gets it documented in your chart so the answer follows you to every appointment from now on. If you have your last kidney labs written down, grab them now. If not, picture the number your doctor read out, the eGFR, the creatinine, whatever they circled on the printout, you'll need it. You know the room. A clinic off the highway near Tampa, you're in the chair. The printout slides across the desk and his eyes go to the vitamin D line. That's 35, our normal range. Keep doing what you're doing. He circles it, slides the page back, and he's already turning to the screen. And you're sitting there thinking, then why does the hip still ache? Why did the bone density scan last year say declining? And why hasn't anyone connected those two things to my kidneys? But you don't say it, because you don't have the words. So you drive home on I-75 and the supplement bottle is sitting on the kitchen counter where you left it this morning. And that night the question comes back, the one you didn't ask because nobody gave you the framework to ask it. Pause. By the end of this hour, you will have the words. Here's who's watching this right now, and it matters because the entry point is different for each of you. The first group just got a CKD diagnosis, stage 3, maybe 3A, maybe 3B, and they've been told to take vitamin D, they're taking it. The bottle is on the counter. But nobody explained what the kidneys have to do with vitamin D, and they're not sure the supplement alone is enough. If that's you, stay, because the mechanism I'm about to show you is the reason supplementing by itself may not work at your stage, and you deserve to know that before your next lab draw. The second group has been managing kidney disease for a year or more. They're on the ACE inhibitor, they're watching sodium, their eGFR still slipped. And somewhere in the last year, a bone density report came back worse than expected, or their parathyroid hormone came back elevated, and nobody connected it to the vitamin D conversation. If that's you, this video will explain why those numbers moved, not a guess, a named mechanism. The third group doesn't trust the supplement aisle and doesn't want another pill. They want to understand what's happening inside the kidney before they agree to anything new. If that's you, the mechanism is exactly where we're going. And by the time you hear it, you'll understand why this isn't a supplement pitch. It's an enzyme problem. No matter which of the three you are, the mechanism underneath is the same. And it starts with something your kidneys used to do automatically, a job they may no longer be performing well enough, and a blood test that was never designed to catch the difference. Most people think of vitamin D as something you get from the sun and swallow in a capsule. That's the first half of the story. The half that almost never gets explained, and especially not in a kidney context, is what happens after the vitamin D enters your blood. When sunlight hits your skin or you swallow a vitamin D supplement, the molecule travels to your liver first. The liver does a partial conversion. It adds one chemical group and produces something called 25-hydroxy vitamin D. That's the form your doctor's blood test measures. And this is the part that changes everything. 25-hydroxy vitamin D is not the active form. It's a storage molecule. It's raw material sitting in the warehouse, waiting to be processed into something your body can actually use. The processing happens in your kidneys. Inside the cells of the kidney, an enzyme called 1-alpha-hydroxylase takes that storage molecule and adds one more chemical group, converting it into 1,25-dihydroxy vitamin D, also called calcitriol. Calcitriol is the finished product. It's what gets calcium into your bones. It's what keeps your parathyroid gland quiet. It's what regulates your immune cells. It's the form that does the actual work. Think of it this way. Vitamin D is crude oil. It arrives in your body as raw material, and raw material by itself doesn't run anything. Your kidneys are the refinery. The refinery takes the crude and converts it into usable fuel, calcitriol, and sends that fuel out to the systems that depend on it. When the refinery runs at full capacity, everything downstream gets what it needs. The bones stay dense, the arteries stay flexible, the parathyroid gland stays calm. But when the refinery slows down, when kidney function drops to stage 3 or below, you can fill the warehouse to the ceiling with crude oil. It won't become usable fuel unless the refinery processes it. And a test that measures how much crude oil is in the warehouse tells you nothing about whether the refinery is keeping up. That's the situation Dr. Rachel LeClair's team documented. Their 2005 study in the American Journal of Kidney Diseases looked at CKD patients across multiple latitudes in the United States, controlling for differences in sun exposure, and found that 71 to 82% had insufficient levels of the storage form. But here's the finding that matters even more for you. Vitamin D deficiency in CKD begins before the other mineral abnormalities, before phosphate rises on a routine panel, before calcium dips. The refinery slows early, and the standard blood test, because it only measures the storage form, can't detect it. 2 years later, in 2007, Dr. Miles Wolfe at Massachusetts General Hospital, Harvard Medical School, published a landmark study in Kidney International. His team measured vitamin D levels in 825 consecutive patients starting hemodialysis, drawn from 569 centers across the United States. 78% were vitamin D deficient. 18% were severely deficient, below 10 nanograms per deciliter. And the finding that carries the most weight is this, bounded carefully. Calcium, phosphorus, and parathyroid hormone levels correlated poorly with the 25-hydroxy vitamin D measurement. The storage form was not reliably predicting what was happening downstream. The warehouse was full. The refinery had stalled. And the blood test couldn't tell the difference. Now here's where this becomes specifically about your bones and your arteries, not just a vitamin number on a lab report. When your kidneys stop making enough calcitriol, a cascade begins. It doesn't announce itself, it moves quietly through 4 stages, and each one feeds the next. Stage 1, calcitriol drops, and calcium absorption from the gut drops with it. Your body needs a certain amount of calcium in the blood at all times, for your heart, for your nerves, for your muscles. When the gut stops absorbing enough, blood calcium dips. Stage 2, the parathyroid glands in your neck sense that dip. They respond by releasing more parathyroid hormone, PTH. PTH does one thing aggressively. It pulls calcium out of your bones to restore blood levels. Blood calcium normalizes on the lab report. Your doctor sees a normal calcium and moves on, but bone mineral density is declining every time this cycle repeats. Stage 3. The kidneys, which are already struggling, can't clear phosphate as efficiently. Phosphate rises in the blood, and the body produces a hormone called FGF23, fibroblast growth factor 23, which tells the kidneys to dump more phosphate into the urine. This is helpful at first, but FGF23 does something else. It suppresses the 1-alpha hydroxylase enzyme even further. The very hormone the body sends to fix the phosphate problem makes the vitamin D conversion problem worse. It's a feedback loop running backward. Stage 4. The calcium being pulled from bone and the phosphate, the kidneys can't fully clear, form a calcium phosphate product. That product doesn't float harmlessly in the blood. It precipitates, it deposits in the walls of your blood vessels. Your arteries stiffen, not with the cholesterol plaque you see on a heart health commercial, with mineral like scale building up inside old pipes. And the cardiovascular risk that kidney patients die from most often is driven in significant part by this mineral process that a standard vitamin D blood test calls normal. This is the CKD-MBD cascade, chronic kidney disease, mineral and bone disorder. Phosphate rises, FGF23 rises, calcitriol falls, PTH rises, bone weakens, arteries stiffen, and it begins well before stage 5. The evidence shows that FGF23 starts climbing as early as CKD Stage 2A, before phosphate is even abnormal on a routine blood panel. The refinery slows before the gauges move. The question in your head is probably this: if the storage form isn't the whole picture, what actually moves this in the right direction? What's the lever? The answer is more specific than take more vitamin D, and once you see it, you'll know why the generic advice from every other vitamin D video on the internet doesn't apply the same way when your kidneys are involved. Here's what moves the needle, and it's not what most vitamin D advice will tell you. The lever isn't more supplement. The lever is understanding that 2 different forms of vitamin D exist, and that your kidneys are the bridge between them. Once you see that, the conversation with your doctor becomes completely different. In a body with healthy kidneys, the system is self-regulating. You take in vitamin D, the liver converts it to the storage form, the kidneys convert the storage form into calcitriol as needed, and the parathyroid gland stays quiet because calcium absorption is running normally. The refinery handles the load. You don't think about it. But when kidney function drops, when the eGFR slides below 60 and especially below 45, the 1-alpha hydroxylase enzyme loses capacity, and the body doesn't wait politely for a fix. It reacts. The first response is FGF23. Bone cells release it to manage rising phosphate. It works. Phosphate gets pushed into the urine. But FGF23 also suppresses the very enzyme that converts vitamin D to its active form. So the body's attempt to fix one problem accelerates another. The refinery slows even further. Next comes the parathyroid response. With calcitriol falling, calcium absorption from the gut drops. The parathyroid glands sense the dip and increase PTH output. PTH pulls calcium from bone. Blood calcium normalizes on the lab. But the bones are paying the price, and the freed calcium combines with retained phosphate to calcify artery walls. What the lever actually looks like, the thing that breaks this cascade, involves 3 specific steps, and each one is an appointment action. First, confirming that the storage form is adequate. This is the standard 25-hydroxyvitamin D blood test your doctor already orders. The KDIGO 2017 CKD-MBD guideline and the National Kidney Foundation's 2018 scientific workshop, published in the American Journal of Kidney Diseases, Agree. If 25 hydroxy vitamin D is below 15 nanograms in a CKD stage 3 or 4 patient, it should be corrected regardless of the PTH level. If it's between 15 and 30, treatment depends on whether PTH is already rising. Nutritional vitamin D, calcification or ergocalciferol, should be supplemented before moving to the activated form. The workshop panel was clear on that sequence. Second, checking parathyroid hormone. PTH is the downstream alarm. If it's rising above the upper limit of normal for the assay used, and your kidney function is at stage 3 or below, it tells you the cascade has started, even if calcium and phosphates still look normal on the printout. This is the test your primary care doctor almost never orders in the context of a routine vitamin D check. It's the number that reveals whether the refinery is keeping up. Third, and this applies when stage 3B or 4 is confirmed and PTH is rising despite adequate storage, vitamin D, discussing activated vitamin D with your kidney doctor. Calcitriol or alpha-calcidoxoer, prescription forms that bypass the kidney's conversion step entirely. They deliver the finished product directly. They're not something you buy in the supplement aisle. They require monitoring because giving activated vitamin D raises calcium absorption, and too much can push blood calcium too high. But when the refinery can no longer keep up, bringing in the finished product from outside the factory is exactly what the KDIGO guideline framework supports. The refinery analogy holds all the way through. Step 1 is confirming enough crude oil is in the warehouse. Step 2 is checking whether the factory's output is meeting demand. That's the PTH test. Step 3, if demand isn't being met, is delivering the finished product from outside the factory. That's activated vitamin D under medical supervision. Sit back for a moment. Let what you just heard settle, because I want you to feel the weight of this. You've been taking a supplement, it was the right instinct. But if your kidneys are at stage 3 or below, the supplement alone may not be finishing the job. And the standard blood test was never designed to tell you that. What you just learned in the last several minutes is the mechanism behind a problem that most vitamin D advice on the internet never touches, because most of that advice was written for people whose kidneys are working fine. If this reframes something your doctor never explained, hit the like button. That's how people in the same situation find this channel. You're probably asking the question that matters most right now. If this mechanism is this clear, if the refinery slows and the cascade starts, and it's been documented since 2005, why hasn't my own kidney doctor connected this for me? The answer is not what you expect. And it's not frustrating the way you think it's going to be. It's genuinely interesting because the reason has almost nothing to do with your doctor's competence. The vitamin D that most physicians learn about in training is the classic role: calcium absorption, bone mineralization, rickets prevention. That knowledge is over 100 years old. It's settled. And when your doctor checks 25 hydroxyvitamin D and sees a number above 30, they're applying that classic framework perfectly. The number is normal. The box is checked. Move on. The non-classic role, the immune regulation, the cardiovascular link, the CKD-MBD cascade is substantially newer. Most of the research connecting impaired vitamin D activation to the bone and artery cascade in CKD patients has been published in the last 15 to 20 years. The Leclerc prevalence study was 2005. The Wolf mortality data was 2007. The KDIGO-CKD-MBD guideline was first published in 2009 and updated in 2017. The NKF scientific workshop that recommended checking PTH before assuming vitamin D is adequate in CKD was published in 2018. Now, here's the structural gap. The nephrologist who reads the KDIGO update knows about the cascade. They check PTH, they consider activated vitamin D, but the majority of stage 3A patients, the earliest and most treatable stage, are not managed by a nephrologist. They're managed in primary care. And the primary care physician managing your kidney numbers is working within a system that gives them 12 to 15 minutes per visit, a problem list that includes blood pressure, cholesterol, diabetes, and 6 other conditions, and a vitamin D workflow that was designed for the general population. Check 25 hydroxyvitamin D, supplement if low, recheck in 3 months. That workflow does not include a step that says, if this patient has CKD, check PTH to see if the conversion is keeping up. It's not that the step was considered and rejected, it's that the workflow was built before the connection was widely understood, and it hasn't been updated for the primary care setting. The KDIGO 2017 guideline update recommends treating hypovitaminosis D as a modifiable risk factor for secondary hyperparathyroidism. It recommends serial assessment of PTH, but it's written for nephrologists. The language is specialist grade. And there is no widely adopted primary care protocol that translates the cascade into a 3-step vitamin D check specifically for CKD patients at stage 3. This is the lag, not a failure. A lag. The research is ahead of the workflow. The guideline is ahead of the exam room. The nephrologist may know. Your primary care doctor, with 17 things on the problem list and 12 minutes on the clock, almost certainly doesn't have a system prompt telling them to connect your vitamin D to your EGFR. And the only way that connection gets made before the guideline catches up in primary care is if someone brings it into the room. The someone is you. Now you understand why the vitamin D on your printout reads normal, while the downstream systems, bone, artery, parathyroid, are quietly shifting. The question is what you do with that understanding. And the answer is a very specific conversation that starts with one sentence. Let's talk about that conversation because it's not complicated and it doesn't require you to argue with anyone. It requires you to ask 4 specific things in plain language and to request that the answers be written in your chart. First, the tests. You want to know 3 numbers. The first one is the one you probably already have, 25 hydroxyvitamin D. The storage form. This confirms whether the warehouse has enough raw material. If it's below 30 nanograms per deciliter, supplementation is the first step regardless. If it's below 15, the NKF workshop panel says it should be treated no matter what the PTH says. The second number is PTH, parathyroid hormone. This is the downstream signal. If PTH is rising above the upper limit of the assay's reference range, the cascade has started, even if calcium and phosphate still look fine. PTH is the number that tells you whether the refinery is keeping up with demand. Your primary care doctor can order this. It's a routine blood test. It's covered by standard lab panels. It's the number that changes the conversation from your vitamin D is fine to your vitamin D storage is fine, but the active form may not be. The third number, and this one you may only need to know if PTH is elevated, is phosphate. If it's climbing, the cascade is further along. If it's still normal but PTH is high, you've caught it early, which is exactly the point of asking. The fourth is bone density, a DEXA scan. If you haven't had one recently and you're over 60 with CKD Stage 3 or higher, this is the structural check. The KDIGO 2017 update extended its bone density recommendation to include CKD G3A through G5D, a change from the narrower 2009 recommendation. If bone density is declining and PTH is elevated, the pattern is clear. The refinery has slowed and the bones are paying for it. Now here's the sentence. The exact words you bring to the appointment. Doctor, I know my vitamin D level came back in the normal range, and I want to make sure the form I'm taking is actually being converted to its active form, given my kidney function. Would you be willing to check my parathyroid hormone level and note in my chart that we discussed whether my current vitamin D plan is appropriate for my CKD stage? That's the sentence. Write it down. Put it in your phone. Carry it to the appointment. Here's why the chart documentation request matters. If your doctor checks PTH and it's normal, great. That goes in your record and you have a baseline for comparison at every future visit. If PTH is elevated and your vitamin D storage is adequate, you've just revealed the refinery problem, and the conversation about activated vitamin D becomes a natural next step, documented and tracked. Either way, the question is in the chart. It travels with you. If you change doctors, if you're hospitalized, if you see a specialist, the question you asked today is in the record. Now let's walk the 3 possible responses. Response 1, your doctor already knows this. They check PTH regularly. They say, yes, I've been watching that. Here's where your PTH is. This is ideal. You now have the number, you understand what it means, and you can track it. Ask them to note that you discussed the connection between your vitamin D, your PTH, and your kidney stage. Response 2. Your doctor is willing but hasn't connected these specifically. They order the PTH. They may look at the phosphate. They may not have thought about it in the context of your CKD stage before. This is the most common response, and it's a win. You just move the workflow forward by one step for yourself. Response 3. Your doctor declines or says the vitamin D level is all that's needed. Don't argue. Don't get frustrated. Don't threaten to switch doctors. Say this: I understand. Would you be comfortable noting in my chart that I asked about whether my vitamin D conversion is being affected by my kidney function, and that I requested a PTH check? That way, it's documented for my next visit or for a specialist if I see one. That chart note is the tool. It protects you no matter what the answer is today. There's one more thing you should not do. Do not buy activated vitamin D, calcitriol, on your own. It's a prescription medication for a reason. It raises calcium absorption, and taking it without monitoring can push blood calcium to dangerous levels, hypercalcemia. The whole point of this conversation is to bring the question to the right person, with the right data, so the decision is made safely. The supplement you're already taking, cholecalciferol, ergocalciferol, whatever your doctor recommended, stays. It feeds the warehouse. Whether the warehouse needs a different output channel is the doctor's call, not yours. You have the research, the mechanism, the sentence, and the chart request. But there's one more thing. The thing that makes this work, not just at your next appointment, but at every appointment for the rest of your life. Sit back for a moment. Picture this. It's 3 months from now. You're back in the chair. The printout slides across the desk. But this time, you're not looking at the vitamin D line and wondering if it's the whole story. You already know. You have the PTH from your last visit. You know whether it was normal or rising. And when the doctor reads the vitamin D level and says, "That's still fine," you don't just nod. You say, "And how's the PTH tracking compared to last time?" The doctor looks at the chart, sees the note from your last visit, the question you asked, the PTH result, the connection to your CKD stage, and now you're having a conversation that most patients at your stage never have. Not because you argued, not because you Googled something alarming, because you understood how the refinery works and you asked the right question. Now picture a second scene. A week after that appointment, you're on the phone with your sister, or your neighbor, or the friend from the walking group whose knees ache and whose doctor said her vitamin D was fine, and she mentions the bone density report that came back worse than expected, and you hear it, you recognize the pattern, and you say, "Ask them to check your PTH, especially if your kidneys are involved. Here's why." And you explain the refinery, crude oil, active form, the cascade, in about 90 seconds, because you've lived it, and you hand her the sentence. That's the identity. Not the person who memorized a vitamin name. The person who understands that their kidneys are not just a filter, they're a factory. And one of the things that factory makes calcitriol, the active form of vitamin D, is the thread that connects their bones, their arteries, and their immune system to a single organ they've been told is just a little low. The person who checks every lab through the lens of kidney function, not as a standalone number. The person who asks, "Is this result adjusted for my stage?" That skill is portable. It works for vitamin D and PTH today. It works for phosphate next quarter. It works for hemoglobin and EPO when the fatigue conversation comes. It works for every number on the panel because the question underneath is always the same. Is this number being interpreted in the context of my kidney function, or is it being read against a general population reference that doesn't apply to me? If protecting your kidney numbers long-term is why you're here, Kidney Health Essentials is the playlist that covers this end-to-end. The tests to ask for, the numbers to track, the conversations that matter, links in the description. Subscribe so you don't miss what's coming next. Here are the 5 questions people search after hearing this, and the answers are specific. Can I just take more vitamin D to fix this? Taking more of the storage form, cholecalciferol or ergocalciferol, is the right first step, and KDIGO agrees it should be tried before anything else. But if the refinery has slowed enough that PTH is rising despite adequate storage levels, more crude oil won't fix a refinery problem. That's when the conversation about activated vitamin D needs to happen with your kidney team. Is this the same as vitamin D toxicity? No, vitamin D toxicity, Hypervitaminosis D is caused by too much vitamin D, raising blood calcium to dangerous levels. What we're talking about is the opposite problem. Not enough active vitamin D reaching the systems that need it because the kidney's conversion step is impaired. They're different mechanisms. The supplement you're taking at normal doses is not causing toxicity. This is not a reason to stop taking it. It's a reason to check whether it's being converted. Should I ask for a 125 dihydroxyvitamin D blood test? This is nuanced, and it matters. The active form, calcitriol, has a very short half-life. It fluctuates throughout the day. That's why KDIGO and most nephrology guidelines do not recommend routinely measuring it. Instead, they use PTH as the downstream signal. It's more stable and more clinically useful. If your PTH is normal, the refinery is likely keeping up. If PTH is rising, the refinery is falling behind, and the next step is a conversation, not a blood level of calcitriol. This is not a diagnosis. Bring what you've learned to your kidney doctor and let them decide which tests apply to your stage. My doctor says my kidneys are fine, just a little low. Does this still apply? If your eGFR is below 60, you have CKD Stage 3 by definition, and the 1-alpha hydroxylase activity may already be declining. A little low is how Stage 3A is often described in a primary care visit. It doesn't mean the vitamin D conversion is still normal. The research shows vitamin D insufficiency starting as early as CKD Stage 2. The question is not whether your kidneys are fine in a general sense, it's whether the specific enzyme responsible for vitamin D activation is still meeting demand. The PTH test answers that. What's your angle? Why are you telling me this? Because 71 to 82% of people with CKD stages 2 through 4 have insufficient vitamin D. The mechanism connecting it to bone loss and arterial calcification has been documented for over 15 years, and the primary care workflow for vitamin D still doesn't include a step that connects it to kidney function. That gap is worth explaining. This channel doesn't sell supplements, it doesn't run a clinic, it doesn't have a program. What it does is take the research that's already published and hand it to you in plain language with the exact sentence to bring to your appointment. Never change, stop, start, or modify any treatment on your own. Always root through your doctor or kidney team. The wider truth is this: your kidneys do more than filter waste. They make hormones, they activate vitamins, they regulate minerals. Calcitriol, the active form of vitamin D, is one of those factory jobs. EPO, the hormone that tells your bone marrow to make red blood cells, is another. Renin, the enzyme that regulates blood pressure, is another. Every one of these quiet factory functions slows down as kidney function declines, often before the filtering problem becomes obvious on a routine blood panel. The skill this video teaches, asking whether a normal lab result is actually normal for your stage, applies to every number on the panel. The vitamin D question is the one you ask this month. The hemoglobin question is the one you ask next. The phosphate question is the one you ask after that. The underlying habit is the same. Check every lab through the lens of your kidney function, because the reference ranges on the printout were built for a general population with healthy kidneys, and you deserve an interpretation that's calibrated to yours. The refinery is still running. It may be slower than it was, but it's still yours. And now you know how to ask the right questions to protect what it makes. If you've stayed this long, you're not the person who walks out of the appointment with the printout folded in your pocket and a question still sitting in your chest. You're the person who carries the sentence. So carry it. Share this with the one person in your life who's also managing their kidney numbers, the one who takes the vitamin D every morning and trusts the blood test to tell the whole story. Because it doesn't. And now you have the words to explain why. The next video in this series covers the other factory job your kidneys are losing, the one that explains the fatigue nobody can account for. It's already there, and the refinery is still yours. Protect what it makes.